Hi, my name is Audra Hauser. Welcome to my project and poster titled Nurse Practitioner Led Behavioral Intervention Program for Adult Patients with Overactive Bladder. This was my quality improvement project for my DNP. The International Continence Society defines overactive bladder as the presence of urinary urgency, usually accompanied by frequency and nocturia, with or without urge incontinence, in the absence of other obvious pathology. The American Urologic Association includes behavioral modifications as first-line therapy and treatment guidelines. It is also noted that overactive bladder can have significant impact on quality of life, including things like relationships, patients' mental health, coping, pain, happiness, and self-worth. In a rural urology clinic that coded overactive bladder and associated symptoms 1,026 times in office visits in 2020, it was found that only 10% of these patients have been offered behavioral modification therapy interventions. This was determined by provider interview. In this practice, there is no process to provide these interventions to patients. No behavioral therapy program is in existence. Teaching points that were found to be most common in this practice were discussing diet with patients, and the least discussed intervention was pelvic floor physical therapy. This resulted in the lack of first-line therapy being consistently offered to patients with overactive bladder. This can lead to unresolved patient symptoms and ultimately a decrease in quality of life. The program was implemented with the support of current literature showing significant overactive bladder symptom improvement with the distribution of a leaflet and face-to-face sessions with a content expert. The interaction model of client health behavior therapy is a middle range nursing theory that incorporates physical, social, cognitive, motivational, affective, and environmental antecedents to health behaviors. This model gives a prominent contextual role to the healthcare provider or the clinician in affecting positive and negative outcomes. The theory has three elements, including patient singularity, client professional interaction, and health outcomes. These concepts identified by Cox and the evidence-based literature for behavioral modification intervention programs were congruent concepts. Patient singularity included patient demographics and past experiences that were appreciated by the nurse practitioner led. Motivation was included in the face-to-face sessions. The client professional interaction variables included support with extra time and the nurse practitioner talking to the patient that as if they were a team. Health information included patient-provider relationships and the professional competency of this skill in the delivery of the intervention. The OAB program incorporated face-to-face encounters with context experts and supported nursing staff being part of the team. The theory is a holistic approach and is applicable in the outpatient setting. The conceptual framework of complex innovation implementation by Helfrich et al. Was the framework used for this implementation. The framework supports the goals of the project for strong management, communication, and leadership, and this fell into the mission and vision of the facility that it was completed at. The purpose of this project is to provide patients over the age of 18 in a rural urology clinic an educational leaflet and an invitation to 3 60-minute face-to-face sessions with content experts. The short-term goal included that 100% of nursing staff and providers would be trained on the program. The resource of a leaflet and the overactive bladder program. Our also short-term goal was that 100% of new patients diagnosed with the overactive bladder program would be given the leaflet and an invitation to the sessions. During the first 15 weeks of the implementation, the staff were educated in two groups. First, the nursing staff and support staff. The second education session included the 4 urologists at this practice. Patients meeting inclusion criteria were identified by the provider through ICD-10 codes, including R35 frequency, R35.1 nocturia, R39.41 urge incontinence, R32.81 overactive bladder, and R39.15 urinary urgency. A welcome letter to the Overactive Bladder program containing dates and the agenda for each night, along with the educational leaflet, was provided to identified patients. Following distribution of the leaflet, the staff charted in the electronic health record under a specific populated tab that was created by the NP lead. The face-to-face sessions with content expert focused on normal bladder anatomy, diet, bladder training sessions, timed voiding, bladder diary, bowel regimens, and pelvic floor muscle exercises. The face-to-face nights occurred every other week for 6 weeks. The nurse practitioner lead led the first and the third, and the second was led by a local pelvic floor physical therapist. Prior to the first and after the third sessions, all patients in attendance of all 3 sessions completed the Overactive Bladder Symptom Scale questionnaire in a private setting. Results showed that 100% of multidisciplinary staff were educated in the process. The percent of leaflet distribution was completed by chart review by ICD-10 codes, and then acknowledgement in the electronic health record of the leaflet distribution. 186 patients received the leaflet, an invitation to the face-to-face session, resulting in 82% of eligible patients receiving this information. 11 patients presented to all 3 nights. There were 9 females and 2 males. There were 2 patients ranging in the 30 to 50-year-old and 3 patients representing ages 51 to 60, 61 to 70, and 71 to 80. The most frequent diagnosis code of the 11 participants was 32R32.81, which is overactive bladder. No participants had the diagnosis code of nocturia. The Overactive Bladder Symptom Score Questionnaire is a validated and reliable questionnaire that has 7 questions. It is self-reported by Likert. The lower the number, the better the symptoms. There was improvement in all 7 questions to the Overactive Bladder Symptom Scale, comparing pre-intervention to post-intervention, with the greatest improvement in question 1, frequency of urination through the day, and question 5, the number of times this patient experiences sudden urge or desire to urinate that makes them rush to the bathroom. These findings are consistent with the literature. Limitations of this QI project were that it was completed in one rural outpatient center with a convenient sample, and that the face-to-face sample fell just short of being able to do statistical analysis on the Overactive Bladder Symptom Score questionnaire. Behavioral modification intervention programs provide first-line recommended therapy, and really, it's good early treatment in patients with overactive bladder. This program has ran several times now and is currently running quarterly, and the patients that are coming seem to be really happy with improved symptoms, and the word is getting around. The attendance continues to grow. We also have looked at doing a similar program for other diagnosis, and these are things that are in the works. Another aspect of this project that I could examine in the future is quality of life outcomes. I just didn't feel like in the time of my DMP project, there was really enough time to gather really good data on quality of life. There's also some potential in the future to move part of this to the virtual environment. So thank you for listening to my presentation, and I hope you enjoyed my poster. Again, thank you very much.